So, the key here is it's better to work out what your instruments are before you're actually doing it with the patient. And there's always time in the beginning of the case while anesthesia's getting themselves organized, that you should get yourself organized. And so basically you want to lay out the equipment that you think you're going to need and make sure it's going to work for you. And remember, particularly with stores products, because they are what most people use, and that's because they're a very good product, they come as a variety of different lengths of telescopes and bronchoscopes. And so one of the key things I think is useful is if you take, say, a Hopkins rod telescope or endoscope, the very first thing to do is have a look through it and check that it looks okay. If it's got a broken Hopkins rod lens, there's no point getting everything assembled and you work that out when it's in the patient. And so the very first thing to do is have a look. So that's a lovely telescope, there's no tarnish on the lens, there's no broken rod lenses in it. Then what I tend to do is just work out if this is the telescope I'm going to use. So I just visually line it up. Is it going to fit in that foreign body forceps? And so these telescopes come as a variety of different lengths, and often you can expand the range of what you can do, not by just buying an awful lot of telescopes, but using a bridge, which acts like an extender. And so this telescope, I can see, is going to fit beautifully down that foreign body forceps. And as I look down it, I can see that the foreign body forceps, this is a peanut grasper, works beautifully, and this is the perfect length telescope for it. Again, undo, remove, if you put it in, that locks it. And so I know that's going to work. Now, if I say take one of these, the length is wrong, because you can see I'd be way out. And so I'm going to use a bridge. And the bridge is fairly intuitive in the sense that you've got two ends, and one of them will fit and one of them won't. So that fits. If I try it the other way, well, that's not going to get me very far. So it's pretty obvious. You can see there's a notch there, and if you look on the inside, you can see exactly where it's going to fit. So then I can put my telescope through it and lock it in place. So that's all very stable. Now, this gives me optics, but it doesn't give me the ability to ventilate at the moment. Because if this is where your anesthetic tubing attaches, and at the moment, air's going to come whistling out the sides. And so, if I put this in, this is actually meant to provide visualization if you were just looking down it without a Hopkins rod telescope. So it's versatile, but in this day and age, we're all using telescopes. You're not using your naked eye for this. So if I wasn't using my naked eye, I would be putting on something like a bridge, like this, and looking down, and this fully in is just into the loop. It's got a lens on it, a light source, so that fully in gives me the light to look down. And I can either have it with a glass lens, or I can have it where I can put a foreign body forceps down it. So maybe I'll use this one as an example. So I could actually do something like that. Now, in this day and age, you really aren't going to use that very often. So we'll put that to one side. I'm going to reintroduce the Hopkins rod telescope. And you you back this out one notch, so it's not blocking the lumen, but it is allowing ventilation because it blocks off the hole. So most of the time, this very expensive little thing is purely acting as an ability to ventilate by blocking a hole. It's a plug, it's a cork. So a very expensive cork. Now, on this, do we have one of these? Yeah, thank you. So, and I'm going to disassemble this initially, and so this is also where air can come whistling out. So what you do is, again, there's a little notch. You look on the inside of this. There's a place where it will turn and click in place, and then this acts as a valve, so it goes over the top of that. So that's a sort of a rubber nipple, and you can put a suction catheter down here all the way through. Now you've got to line it up properly, and so when this clicks in place, you know you're perfectly lined up. If I do it like this will not, the suction won't go down, but if I spin this, you'll hear it click. That's the right position for the suction to go straight down there. Now, very unfortunately, the bean counters at stores decided that the suction catheters were not making them any money, so stopped providing them. There is a second story behind all of that. There are substitutes. You can use a urethral suction. And so the suction catheters designed for this are no longer available. There's about 4 different companies trying to make them. They will become available. You can use a urethral suction. It's appalling, but it's better than nothing. And so that's how you put the scope together. Now, do you need to use a foreign body forceps down this? And so again, we can introduce something like this, which is going to block the hole. I'm going to take out the telescope from the bridge. I'm way long enough to go past here, and say we use a peanut grasper, and again, you've already looked at it, you know it's going to fit. Whereas if I say, look at this telescope, it's not going to fit, because I can't get it any further past than that, so this is not going to help you. So again, check your instruments ahead of time. This will work, and then you've already put that in the patient, you're in the right position just proximal to your foreign body, and you can now slide this all the way through. As you just come out of the end of the bronchoscope, you typically start opening the forceps so you can see past of what you're doing, and you advance partially open till you're ready to fully open to grasp the foreign body forceps, grab it, and you start pulling it back till you are just in the entrance. You don't really usually want to pull it into the bronchoscope because it will often drop off. But when you're right there, you then pull everything else out en masse, bringing the foreign body with you. So that's the typical technique. Now, again, it depends on your hospital's funding, because all of these come with different telescopes, so you can have everything pre-set up. Our hospital, these Hopkins rod telescopes, do you want to guess how many of these we've got in our hospital? 250, and they're really expensive. But we're a big hospital, we do a lot of bronchoscopies, we're an airway unit, and it's America. We've got a shitload of money. So we've got a lot of toys. Most places don't have that. Work out what you've got and how to make easy to break. These have got Hopkins rod lenses, and if you look through it, and you even bend it a little bit, you'll see an optical shadowing on one side. If you see that, it's telling you that you're bending the telescope. These have got a series of glass lenses in them. Glass will break if you bend it. If you suddenly see a star on one side, you've broken one of the lenses. They're really expensive. Don't do that. If you've got one in your hospital and you break it, it may be a long time till you get another one to replace it. So treat these with respect. They're metal and glass, they give you phenomenal optics, but treat them with respect and they will last for years. But if you're rough, day one, you can break them really easily. Try not to do that. And this is a 2.8mm out of diameter. There is also a 27017 Hopkins rod telescope, which goes inside the 2.5 bronchoscope, which is 1.9mm out of diameter. And that's really breakable. And so again, the smaller the scope, the easier it is to break. And so just treat these with respect. So does anyone have any questions they want to ask me at the moment? Good. Now, try not to be funny abusers today.
Okay. I think thanks from Rutter. For the instruments, I think you know that class thoughts are only surgical. You can get back to them after you go back to the hospital. The accessories, they are very sensitive. The bridge has different length actually, so it depends on the size of the telescope and the ground that you use. I think we can go back to your table.